All right. Hello, everyone. We're so glad that you're all here. Good afternoon on this rainy day. For those of you that don't know me, which I think I know so many people in this room, and I know we have some folks online, my name is Rebecca Silvers. I'm the director for the Center for Global Nursing here at the Institute of Global Health Sciences. And I think today is one of those great days where you get to learn from your colleagues and from people you look up to. And we are very, very honored to have our Dean of the School of Nursing join us today to introduce our speakers. Dean Dawson Rose is here, who, as many of you know, I'm so lucky she's my dean. She has an incredible amount of experience, more than 3 decades working in global health sciences. If you have been to our Impact series, it's recorded and online on our YouTube channel. You can hear about her incredible work across Africa in HIV and AIDS work. She's a pioneer in her field, and I'm so honored that she's here to welcome our speakers today. Without any further ado, Dean Dawson Rose.
It's the picture. You're beautiful. Yeah, it's taken out there next to the plants. Yeah. I'm excited to be here today and supporting the work of the Center for Global Nursing and our relationship in the School of Nursing with the Institute for Global Health Sciences, which is a really important relationship and partnership for us, because so many of our students and faculty are, they're passionate, they're driven to work in global health science and practice and settings. So excited to be here today. I'm overjoyed to introduce our speakers. So my experience is primarily in HIV nursing and HIV care and all things about HIV, and I've been doing it a long time. And across my paths, I met both of these individuals and worked with them over several years and consider them both to be friends. And so I am excited to introduce our speakers, who include Dr. Jason Farley, who is a globally recognized nurse scientist, and the inaugural Leadership and Innovation Endowed Chair at the Johns Hopkins University School of Nursing. He's also the director of the Center for Infectious Diseases and Nursing Innovations at Hopkins. Dr. Farley is a giant in the field of HIV, especially around nursing and infectious diseases and promoting patient-centered care and looking at nursing interventions. He runs several different trials, clinical trials, which he'll talk about today in Baltimore locally, as well as in South Africa. And it's exciting to hear about his research, which really looks at the impact of nursing. Adam Leonard, who is I know Adam because he got his master's in pediatric nurse practitioner training here in the School of Nursing at UCSF, and then we worked together in a community-based project here addressing substance use and mental health, which is sex, drugs, and all that is what you're doing with transitional age and adolescent individuals. He maintains an adjunct role here at UCSF in the School of Nursing, but right now he is a PhD student of Dr. Farley's at Johns Hopkins in the School of Nursing, and is working globally as well. And we'll talk about his work in antimicrobial resistant TB. Is it something really? Close. Okay, there you go. Okay, so I'm going to turn it over to Dr. Farley and welcome both of you. We're excited to hear from you.
Good afternoon, everyone. Let me see if I can get there. It is. I think that's on now. Good afternoon. I think we're trying to do some Zoom recording here, so I'll do my best to stay centered behind the podium, but I will not make strong promises about that. To Dean Dawson Rose, I learn every time I'm in your presence, and you have been an inspiration of mine for many, many, many years in the field of HIV. So thank you so much for the kind and warm introduction. And to all my friends and colleagues, Payam and others who are currently dealing with all of the amazing issues that we're addressing regarding the assault on global health, the assault on HIV, the assault on tuberculosis-related funding, with you in solidarity. So we will be addressing in this talk the critical social and structural drivers associated with tuberculosis and HIV treatment in South Africa, and how we've nested a variety of different social and structural determinants of health within the trials that we have done. But when I'm speaking to a nursing audience, I always like to start, because very little coverage for tuberculosis occurs in nursing school textbooks. I mean, these days it's very little HIV as well. So we probably should do a whole background there. But when we think about TB as a disease, it is the world's leading infectious disease killer, replaced briefly for a period of time from COVID-19, and has returned to one of the world's leading infectious disease killers, particularly for people with HIV. And what you can see here is whether it's on a chest x-ray that's, and you can see a major cavitary lesion in a patient, or if you see in the postmortem evidence of tuberculosis and how it physically eats away at the patient's lungs, resulting in, as you can see from the patient presented here, loss of weight, emaciation, potential for shortness of breath and dyspnea, and many other myriad of symptoms. The patients often struggle with lots of stigma, issues around late presentation to care. You can see this gentleman here clearly presenting late into treatment with significant emaciation, weight loss, but yet there's been a lot of progress in the space of tuberculosis treatment and management. And for example, the hands that you see before you are a photo from the TB Alliance, presenting a drug-resistant antimicrobial regimen from your view on the right, with all those pills and the sachet of medication called PASS, and then where we are currently sitting with antibiotic-resistant tuberculosis on the right. And if we just remind ourselves that tuberculosis as a disease is 100% curable with the right circumstances. Right? We've had the agents for treating tuberculosis, some streptomycin and INH, since the 40s, and have been able to cure patients with tuberculosis. Has anyone heard much in the media presently about the ongoing U.S. tuberculosis outbreak in the states of Kansas and a few others? Right? So this isn't just a global health issue. This is an issue present and near present danger here in the United States. Most of those individuals who develop latent infection and will probably not all go on to develop active disease. But let's turn our attention now to the journey of a patient in South Africa. And so contextually, in rural South Africa, patients often sit in their homes in rural areas far away from the traditional healthcare space and place. And when we think of social and structural drivers of health and health outcomes, I'm talking about places where people live, work, and play, and how they interact in their normal lives, which is external to the healthcare system. We're trained in nursing, medicine, public health, pharmacy, that the interventions we offer, patients should flock to us, right? They should seek care, they should come to us. But people don't live their daily lives in that context and in that structure. And so what I like to think about is how do we evaluate what the daily life and structure is of a patient population we're trying to engage, and really think about what it takes to get an actual tuberculosis diagnosis. What is the context in which, if I'm in a rural care setting, I'm coming into primary care? I may make that journey into a primary care clinic repeatedly before I ever get an actual diagnosis of TB. Standard treatment guidelines say if I present with a cough in South Africa, the nurse that is seeing me for my treatment, 98% of the time it's going to be a nurse, has a standard protocol. New onset cough, provide standard antimicrobial therapy with amoxicillin for 2 weeks and have the patient return in a syndromic kind of management strategy, right? And so they may go back and forth because they may see a different nurse the next time who may or may not know that they received 2 weeks of antibiotics, and the patient may or may not tell them. So in that primary care setting, it depends on the clinician's confidence, their diagnostic capacity. Do they have the right test? Do they have molecular diagnostic testing? Are there resources for helping the patient get back in the clinic? Are there possibilities of integrating such diagnostic services for TB within the HIV treatment program, for example? Once a diagnosis, particularly of antimicrobial resistant tuberculosis, is made, so that means the classic treatment regimen of what we would call RIPA-4 or INH, rifampicin, ethambutol, and in South Africa it would be INH, rifampicin, ethambutol, and why am I blanking on the fourth drug at this moment? Parazenamide, thank you. We don't use it in drug-resistant TB, so I'm like, what drug am I talking about? Parazenamide. They're resistant to at least one, if not two, of the drugs in that regimen. Meaning, classically, we would be referring to this hospital that you can see here, and in that hospital, they would be admitted for up to 6 months for daily injectable therapy. Can you imagine, as a nurse, thinking about the patient I showed you before, or the one we see here on the screen, giving a 3 milliliter injection into that patient and finding the right muscle mass to be able to do an IM injection in that patient, right? 1 in 4 patients would go deaf in that regimen in this context. So, but once they're there in that circumstance, and that's why moving from that regimen that I was showing you before with all the pills, I didn't show you the one with the injection, to now what we have in the small pill burden for drug-resistant TB is so essential. But we move it, it still sits most of the time in this hospital-based setting, and I'll show you some distance to care related studies that help us juxtapose what distance from that patient's home to their actual treatment regimen they have to travel. So but once at that facility, who's providing the care? We often would see specialist physicians who, if there was any reason why the specialist physician was gone, there was one physician treating the patient, if they were no longer present, the nurses would be forced to take over the management of the drug-resistant TB patient, possibly be 6 months for maternity leave, possibly the physician got another job in another site, and they would be a year or more without a physician in the site. All the while, the nurses were managing the patient to keep the program running. So we began exploring, could we evaluate and think about other alternative strategies and models? So the first study I did, this was a study of, at the time, the world's largest DRTB treatment cohort called the DOTS Plus cohort. And my colleague at the Medical Research Council, Dr. Marty Vanderwalt, and I had the opportunity as a PhD student to work with her on evaluating this study. And the DOTS Plus study was a prospective observational cohort study and during the years of 2000 to 2004. So South Africa during that time was experiencing a Minister of Health, similar to RFK Jr., in which they did not believe in antiretroviral therapy. Beetroot was the general recommendation for treatment of HIV. And you had a Minister of Health actively describing seeing a traditional healer, taking herbs, and other related activities. So we didn't see a lot of patients on ART in this study. But I needed to understand and evaluate what are our actual treatment outcomes across these multiple sites. So we did a competing risk analysis because a patient with drug-resistant TB can fall into one of 4 categories. They can live and be successfully treated, or they can die. They can leave treatment or be lost to follow-up. Here it's referred to the word default, which is a term that we no longer use, but at the time was the current terminology. And then had various negative other competing outcomes. And then we did a Cox proportional hazard model to evaluate. We found that 1 in 5 patients, about 21%, were lost to follow-up or that default. 9% would fail treatment, and 23% died during therapy. And there was significant difference in death by HIV status. Remember, there was no access to antiretroviral therapy for the majority of patients. And you can see here in this competing risk model that if you were male, you were more likely to fail treatment and fail treatment faster, and it has a ratio here, under 1. If you were living with HIV, you're more likely to fail treatment. And failure in this context means you developed worsening antimicrobial resistance. So your 6 to 8 drug regimen, some of those drugs stopped working, and you developed worsening antimicrobial resistance. That's the definition of failure. If you were failing, but you died before the microbiologic result came back, you were classified as a death. You can only fall into one of those categories, even if the reason you ultimately died was emerging treatment failure. You can see that by weight group, those with less than 60 kgs, those with less than 45 kgs had a substantially greater risk of failure, or greater odds, hazard ratio of failure. And then you can see for death, HIV status significantly increased the odds, or the proportion of the hazard to death, as well as the weight group under 45 kgs, as well as those in less than 60, 45 to 60 kgs. Now, importantly, when I look at this as a nurse scientist, I'm thinking, okay, well, why would someone present so far in their treatment that they're already presenting with their weight so exceptionally low? Now, TB causes emaciation, it takes away, but why these late presentations to care? Well, there's the co-infection, right, of HIV, and that causes weight loss as well if it's untreated. But oftentimes patients, when we would talk to them, would say to us, it's the distance to treatment. They told me I was positive for antimicrobial resistance to TB. Then they told me I was going to be admitted for 6 months, possibly, for treatment. And they told me that I couldn't bring my kids. I had to figure out somewhere for my kids to be for potentially 6 months. So they would wait until they were literally on death's door before they presented to care because they had no other option. So that's where I kind of began this journey, trying to figure out, well, why would patients present so late to care? And then really thinking about what strategies would assist us from getting the patient from that home down to that treatment regimen that we know, and really unpacking the social and structural determinants of health. And really that access and retention depends on so many factors from a patient's lived experience. And the treatment is free, but the cost to get to treatment is not. The treatment is free, but the missed income from work is not. All of those structural and issues, the treatment might be free, but if I'm stigmatized by trying to take public transportation because I've lost so much weight and I'm coughing, huge barriers to treatment and care. And then ultimately, once we get the patient in care, can we retain them in care? So the patients were speaking a whole different language than the clinicians during this process in the early days of drug-resistant TB, and we really wanted to begin to unpack how we could improve this. So the South African CDC funded us to do an evaluation of, since we saw so many nurses already leading treatment when doctors were absent, could we actually prove that the treatment outcomes of these patients were equivalent to that, or at least observationally similar to that of our physician colleagues? And so the CDC funded us to do a programmatically based intervention. Because it was PEPFAR money that funded this work, the R word, direct R word in research was, not the strongest and most important word. So they said, no, we need you to design a program, implement the program, and retrospectively evaluate the program through a retrospective cohort evaluation, which is what we did. So from 2012 to 2015, we began looking at can a clinical nurse practitioner, which is a nurse in South Africa who has an advanced a 3-year diploma with a 4th year of training in primary care diagnostic evaluation and primary care management. So just in comparison, so you understand the context of when I use the word nurse practitioner in this setting, we're not talking about a master's or a doctorally prepared nurse. We're talking about a 4-year training program in this context. So we set out a very easy criteria programmatically, and we said that patients with a BMI less than 18 were uneligible to be treated by the nurse, and if the BMI was 18 or more, they could be treated by the nurse, regardless of HIV status. And so in this one site, a single center study, there were 197 patients who presented during the study period. You can see on average the age was 33 years, it ranged from 26 to 40. 51% were female, and the BMI was approximately 19.7. Okay, and you can see that there's a distinction in BMI, appropriately so, a statistical difference between those in the CNP arm versus the medical officer or the physician arm. And it is that finding right there in the BMI, I don't think I highlighted it, maybe, I didn't. that finding in the BMI drives the outcomes that I will show you on the next slide. The overall MO's BMI was 16.9 and the CMP's was 19.9, so automatically there's confounding there based on that BMI. But when we look through the rest of the data, similar findings in employment, similar findings in HIV status, the median CD4 count between the two groups was 250 overall, but slightly lower in the CMP arm than in the medical officer arm, but not statistically different. We also saw that from the time of their diagnosis to the time they initiated treatment was on average 71 days. The median was 71 days. So a very, very large number. You've got an inpatient with an infectious illness and spreading that infection within their home and likely within their community. Data we saw presented here at Croy seems to suggest that more casually based contacts from anyone within a kilometer or two from someone's home may actually result in the most common likelihood of infection as opposed to necessarily within household contacts in many settings. And you'll also see that very few patients were treated in the community. Back to what I said is that the majority of patients were hospitalized. So here you can see between the patient assignment that cure rates in the nurse arm was 61%. This was a 24-month treatment regimen, so we'll start there. And in the medical officer arms, again with that channeling bias, the cure rate was 52.7%. Now overall for the entire country during the same study, we evaluated the external evaluation of the data from the National Department of Health, and the overall treatment success rate for the entire country was 60%. So when you marry these two protocols together, our overall treatment success rate for the entire cohort of patients was about 62% overall. So we got just slightly better than the national average in the cohort, but the reason you see the medical officers having lower cure or treatment success there and greater death is because of that lower BMI that I mentioned before. Here, highlight the death. So with that, and us showing to the CDC that with the right selection of patients, nurses could successfully manage patients and get outcomes similar to the national cohort of patients overall. And this again was in the setting and that circumstance of having access to ART, but the ART was our older regimens of efavirenz-based treatment regimens. And at the time, in the period of the study, we switched from a multi-day regimen to a single tablet regimen throughout that study. So there were some ART changes throughout. But we wanted to ask this key clinical question of how can we shorten that time? I said 70 days, right, from the prior study. So can we use any form of health system strengthening approach to shorten the time? And what strategies would assist us to improve faster linkage to care? All during that time, the health system had began rolling out nucleic acid amplification testing, or PCR testing, using the Gene Expert, which you can see at the bottom left there. And we moved from traditional culture methods, although that's an agar plate and not actually a Jensen-Nielsen stain, but we went from traditional culture measures to actual molecular testing, which shifted the time to positivity from anywhere from weeks up to 42 days before the South Africa program calls it a culture negative result, to 90 minutes. So 90 minutes sounds great if I have a test, I'm giving you a sputum, you're analyzing it one-on-one, but when you're talking about one of the largest TB programs in the world, 90 minutes still has a lot of turnaround time associated with it. The sputum may sit for days before it's actually processed in the lab. So again, walking us through this journey and then thinking about that diagnostic testing and resources for linkage, how can we improve at a primary care clinic the ultimate identification of tuberculosis, screening for that patient in that setting? So hopefully you're now seeing this opportunity in which we're trying to shift. The diagnosis typically would not happen until here, okay? But we're shifting through the NAT testing diagnosis to be hopefully able to be happening in the actual primary care clinic. And so that NAT testing had made that shift incapable and possible. So we began to evaluate a technology-oriented solution to identify new NAT-positive specimens with rifampicin-resistant tuberculosis. We designed a series of applications over an 18-month process, got up to app version 15 before we actually deployed the system through a rapid agile design approach and methods, and then implemented a prospective observational cohort across 3 clinics in KwaZulu-Natal in 2015. And to accomplish that, and this is why nurses are so amazingly great at this type of science, is that we get the health system structure. We can walk into a system and understand patient flow and patient movement very well through the lens of the patient. And one of the things that I ask my PhD students, and I did it myself, anytime I'm bringing someone to South Africa is, I'm assigning you to this patient. Your job today, it's a brand new diagnosis, is to just follow this patient around and observe every single point that they have an interaction with a healthcare worker. Write it down. Where did they go? Who did they see? How long did they wait? Where were the pain points? Just observe. And so through that process, creating a process map like this is what we sought out to do. Because I am a personal anti-technology person when it comes to app-based health interventions. Let me be clear about that. Because I think they try to solve too many problems and they don't know actually the mechanism by which the app is supposed to be solving the problem they're trying to design. Without a clear process map of the health system intervention, you can't actually know where is this app working in this process. So here you can see that we completely mapped out the process of having a patient collect a sputum at a primary care clinic, which is by a nurse. The diagnosis is made by a nurse. The patient is given the result by a nurse, and they are then referred by that nurse to the appropriate treating clinician. And what we showed with this process is that we needed 3 separate applications. That the primary care clinic nurse was different than the linkage to care community health worker officer in getting those results. And then the actual MDR-TB clinic was a completely different set of applications. And so we designed, this is what it kind of looks like overall, but I'm showing you the one image there on how we made it completely accessible to a community health worker when they saw a lab. And then they had in the application, all their job was is to look at their patient list and is this patient been contacted to give their results. And the community health worker, so we took the diagnostic result exchange from the nurse, handed it to the community health worker. Now, one of the best things you can ever do when you're talking about nurse science is to take a TB nurse who's got a stack of labs this big and tell her that you're going to take 50% of those away. Just by this application. You've now really transitioned her workload in a routine basis, right? And so the community health worker would take these results, evaluate them, contact patients, and then link them to the care. And over this period of the study, we screened 6,000 individuals across 3 different health centers that I mentioned. Just for time, I won't go into the differences in each of the facilities. But we screened 6,000 healthcare workers. And in this process, we found that about 10% of the patients, about 600 people tested positive for TB. And overall, in the entire sample, MDR-TB was about 1% of patients. And so of the total TB patients, 13% of the total with TB, so the 600, 13% had rifampicin-resistant TB. And for the first time conclusively using this approach, we got from the average of 71 days in the pre-molecular diagnostic evaluation to the molecular diagnostic evaluation of about 14 days, we were able to demonstrate linkage to treatment, so treatment initiation within 3 days, 21 hours, and 17 minutes. So the National Department of Health had set a goal of getting treatment initiated from the time of diagnosis to treatment start of 5 days. And most people said it was impossible, it could not be done. It is possible, it can be done. It just has to be done through the right lens and the right structure and the right approach in order to facilitate it. So working with the National Department of Health, the lab system, bringing in those labs into the app, which quite frankly, this would have probably been even shorter had we not had at least a 24-hour delay from the lab once the result was available. So linkage to care really possible. However, you'll note that of the 41 patients who were not already in hospital by the time we got the lab results, 5 of them, 3 were lost to follow-up after their diagnosis. within 3 days, could not find them again, and another 2 had died within those 3 days. So again, improving patient adherence. Can we think about this differently? Now we can get patients linked to care, we can get them linked to care fast, but now in through this cascade, we've got this other end in this green box of how do we improve patient adherence? And so I wrote a cluster randomized trial evaluation to the National Institute of Allergy and Infectious Disease, and they funded this work in 2013 to evaluate nurse case management for the treatment of drug-resistant tuberculosis. And we were really looking at, could intensive case management from a nursing lens improve treatment outcomes, reduce loss to follow-up? And there was no real nurse case management model that helped to harmonize the various types of really caustic, side effect-driven treatment regimens that we had to offer our patients. So this was a small cluster randomized trial, and at the time we had 10 MDR-TB hospitals. And we've corrected in our analysis for our small cluster sizes, but today I wouldn't do a cluster randomized trial with only 10 clusters. But at the time, first R01, that seemed like a hell of a lot. So our total sample size that we were seeking for in this patient population was 3,000 patients across the 10 hospitals, or 300 per hospital. We used the standard WHO treatment definitions in 2020, and we looked at GEE, or generalized estimating regression analysis, with log link for with multinomial outcomes. And ultimately, the intervention model looked like this. So there were 5 domains applying the chronic care model, which is a model traditionally used for diabetes and other chronic related illnesses. The chronic care model sits with me with a 24-month treatment regimen with tuberculosis very well, because obviously we're treating these patients over a very long period of time. And so many of the chronicity related items within the chronic care model work well. Across the 10 hospital centers, we ultimately enrolled 2,847, and Dick Chason will say to me that I had a little too much tunnel vision, wanting only rifampicin-resistant TB, and not wanting to include the XDRs, and I'm like, Dick, 20% of XDR patients live at this moment. Like, I don't really want to include the XDR patients in this, they're all going to die. But it wound up excluding in a good proportion. You can see that pre-XDR and XDR patients, there were 385 that we had to exclude. And then because we only had 10 sites, there were 54 withdrawals moving, transferred out to a non-participating site at 189, and then 54 patients who withdrew from another reason. There was incarcerations and many other things. So in our intent to treat analysis, there were 2,136 patients. You can see how they divided. For the sake of time, and to make sure I give at least 10 or 15 minutes for Adam to present his nested work as well, I won't go through this. I'm happy to answer any specific questions. I have the data on both the HIV positive and negative. You'll see here that unlike our prior study, 74.3% of patients in this study had access to ART. So no patients in the DOTS plus cohort study of about 3,000 patients. In this patient population, about 2,100, the majority with HIV, 74% with HIV, the majority had access to antiretroviral therapy at 71% of those. So when we look at the outcome dichotomously, which was never our intent, but I wanted to show this, versus success versus unsuccessful treatment outcomes, there's no statistical difference. And I show that because a lot of TB studies, when they're, in particular nurse case management studies, will also look at whether or not treatment was successful, and all negative outcomes get lumped into this conglomerate negative unsuccessful outcome. That was never our intent. It was always a multinomial approach, as I showed. And what you can see here is statistical differences between the groups. What surprised me the most, and I'll move right into our multinomial GEE model and with the adjusted analysis. And what you can see here is that nurse case management was successful in reducing treatment failure, so worsening antimicrobial resistance, i.e. they ensured better adherence in the patient population, and reduced treatment failure by 45% in the intent to treat analysis. But what I really thought they were going to actually do was improve and reduce loss to follow-up. So my main hypothesis is they were going to keep patients engaged in care over longer, even if they failed the treatment. But what they actually wound up doing is helping the patient adhere to a very caustic regimen better over time. So what we saw here is that reduced odds of treatment failure among participants, yet they did not statistically benefit loss to follow-up. And we did sensitivity analysis to see if they were more likely in the nursing arm to enroll really sick patients because they thought, I can really help this patient. And it didn't seem, because one arm only had research assistants, one arm had the nurses primarily deciding who was enrolled. And we did the sensitivity analysis, and there were no difference in patients who died between the two arms. They were successful in supporting patient-level treatment adherence, but loss to follow-up was multifaceted, and poverty and the catastrophic cost associated with treatment, they had no intervention in which they could intervene upon. So they couldn't address those barriers. Fidelity was evaluated across the nurse case management, and just like depending on patient volume and how much the nurse had enrolled in a given period of time, really did impact her fidelity to her intervention. When there was lower periods of new diagnoses, you could see the intervention increase in the amount of interventions provided to the patient. But when there were high volume enrollment periods, fidelity to the actual nurse case management intervention declined. And then of course the small cluster numbers were adjusted but could have influenced the findings. So now taking this data and looking at it more deeply, we evaluated median distance to treatment into that study. And this is one of my doctoral students, Katie McNabb, who's currently an EIS officer. I guess she's current now. She was fired and then rehired, and now she thinks she's back as an EIS officer. But she's an EIS officer as of today who led this analysis as part of her Doctor of Nursing Practice PhD dual degree, in which she was becoming a nurse practitioner and a PhD at the same time. So the median distance to treatment was 41 kilometers for all patients across the study, and you can see those distances in which she geomapped those using R in the heat map there. But 25% of patients in KwaZulu-Natal and in Eastern Cape provinces traveled 60 kilometers or more to receive treatment in that study. So my colleagues, Norbert Njeka and Prof. Denise Evans at HERO, have evaluated the cost of such regimens and how much does it cost and what are the major drivers of such cost. So in group 3 to the right, that's the regimen I was just talking about. That's the regimen they used, the 24-month regimen, as we called it at the time. Group 2 was a shortened regimen that has been recently introduced in South Africa over the last 5 years. And then the most recent is the smaller pill burden that I showed you called the BPAL regimen, which is a group of 3 drugs. South Africa also adds levofloxacin to that, making it a 4th. And what you can see here, I think I highlighted that, is you can see, I'm told for Zoom only to walk this direction, so I apologize over there. But you can see that travel, listed here, across all 3 regimens, is the majority of the cost for patients. And we have the data that goes hand in glove with that, as I demonstrated from the prior rifampicin-resistant TB cohort. But what you can see also is that treatment with the newer regimen reduced costs for the patient by 75%. Leading us finally to the current cluster randomized non-inferiority trial that we're implementing called Bring BPAL to Me. Because in my mind, all of this work has been leading me to this penultimate study, which I am super excited to share with you today. We just had our second DSMB meeting last week. Got a really big green light to continue. Let's hope funding does. But so the Bring BPAL to Me trial is to say, okay, we've got the data observationally that nurses can do this work, but now we have a brand new regimen, right? An even easier regimen that actually aligns almost synergistically and perfectly with drug-susceptible TB. It's a 6-month regimen. Both are 6-month regimens now. Pill burden is actually lower in the BPAL-L regimen than it is in the RIFA-4 regimen. Nurses get 90+% treatment success in a RIFA-4 regimen in a primary care model. So can we totally change the paradigm? So outpatient nurse-led treatment will be non-inferior to that of physician-led management is our first primary hypothesis, regardless of HIV treatment. The proportion of serious adverse events will not differ by blinded, independent, physician-led safety committee review. And our patient-associated catastrophic cost, which is defined as 20% or more of household income, will be lower in nurse-led treatment. Again, the benefits of this regimen: shorter duration, fewer pills, higher tolerability, higher cure rates. We should expect and have hypothesized a 90% cure rate. So at the end of year 2, what are we finding? I'm going to walk through a couple of nested questions. So first thing that we're able to tell the program in the country is who is actually eligible for primary care management. That's a quintessential question for drug-resistant TB. The standard approach is you must centralize care for drug-resistant TB patients, and it must be done under specialist, not just generalist physician care, specialist TB treatment care, which we're clearly showing, and I won't identify which arm is which, but you can see in treatment success between these two arms that we've got 92.7% success in arm 1 and 89.2% success in arm 2, and that was only because of a car accident and one other TB unrelated death that occurred in arm 2. Prior to that, recently before we locked this data set at the end of January for the DSMB meeting, they were absolutely equivalent proportionally after 2 years in the study. So we're also able to tell the program how many patients are presenting so late to care, because one of the big questions of the TB hospitals, the drug-resistant TB hospitals, are you trying to close our doors? There's a good proportion of these patients who walk in who are so sick and so present so late to care that they're immediately referred for hospitalization. You can see we've been referred as of January 31st, 832 patients, and 213 of them did not meet criteria for management in primary care, either research, with an additional 86 patients excluded once they got to either the nurse or the doctor for those reasons as they say on the slide. We're also looking at community bedaquiline resistance. So one of the cornerstone drugs in the regimen of BPAL, it's only a 3-drug, possibly a 4-drug regimen, and if one of those drugs is resistant, you automatically weaken the regimen. 7 cases of resistance in one arm, and they're all in different communities. They don't seem epidemiologically linked, and we're working with the National Institute of Communicable Diseases to evaluate that epidemiologic linkage. And then who, once they start in a primary care clinic, can't stay in primary care. So right now there's only 10 patients in each arm who, once they started treatment, can't continue in primary care. So it's equivalent across those arms. And then we follow them for 6 months post-treatment. We're also evaluating and integrating substance use screening and testing. And you'll see on this a lot of surprises. This is the first study to document this high proportion of fentanyl positivity in patients with drug-resistant tuberculosis. This has raised so many bells and whistles that the Narcotics Enforcement Agency in the country has contacted our team to unpack this in a greater amount of evaluation of this data. But you can also see significant amounts of alcohol use as an alcohol metabolite in our point-of-care test, 12% methamphetamine, and about 27% cannabis use in the population. Despite a pretty high prevalence, a higher than expected prevalence of substance use, we're still getting 90% treatment success in the population. So one of the other big points I'm trying to make to the Department of Health, which says, oh, they're a substance user, admit them, is that patients can be actively and appropriately managed with substance use in a primary care setting and still get successful treatment outcomes in a very low resource context. And just for the sake of time, to turn over to Adam, just a huge set of acknowledgments. We're both going to take questions at the end, but let's let Adam tell you about a nested study that he's running here in the BB2 trial.
Well, I know we're approaching the end of the hour, but I do want to just say what a pleasure and honor it is to present with my current mentor, Dr. Farley, a longtime mentor, Dean Dawson Rose, and also a colleague and inspiration, Dr. Silver. So with that, I will just kind of quickly move us through some considerations around some improved patient-centered models of care for patients undergoing treatment for drug-resistant TB, and particularly evaluating HIV risk and potentials for co-locating HIV prevention services alongside TB care. So, we know that patients in TB care, just even with improving regimens, still spend a lot of time in care, up to 9 months for treatment and 12 months total for follow-up. And for patients living with HIV during this time of TB care, we oftentimes see improvement in viral suppression because of this contact with the healthcare system. And there are lots of models about integrated TB and HIV treatment, particularly about implementing HIV treatment into TB services or implementing TB preventive therapy into HIV treatment services that are widely acceptable and effective. But yet there are still 37% of South Africans with drug-resistant TB who are not living with HIV. And so with that, we're wondering about the role of HIV prevention for this group, knowing that people living with TB still report ongoing vulnerabilities to HIV infection. And you see some data here just about some of those vulnerabilities about condom use, history of a bacterial STI, partner living with HIV, particularly those partners who are not virally suppressed on ARVs. But despite this ongoing vulnerability, there's been little attention to how we integrate PrEP into our TB care, despite knowing that, of course, PrEP is safe, effective, and available widely in South Africa. And there's no drug-drug interactions with the BPAL-L regimen, so clinically it's appropriate for use in this patient population. So this work is situated within the Bring BPAL to Me trial, which Dr. Farley just reviewed, and you can see a little bit more about the trial there if you'd like. But we wanted to describe HIV vulnerabilities and assess awareness of and engagement in PrEP among people receiving TB care in South Africa. So, we're following patients prospectively within the BPAL study. And so we have, the data are collected by both the research assistants and clinicians at baseline, really looking at HIV status, both self-report and the point-of-care HIV test at enrollment, and then self-reported sexual activity and PrEP awareness. We also are looking at syndromic STI treatment through clinician visit notes and medication logs. So in South Africa, the standard of care is to treat STIs syndromically versus molecular screening. So if a patient presents with classic symptoms of an STI, they're just treated presumptively for all STIs. And then we're also looking at PrEP uptake, both through the PrEP questions that patients are asked, as well as their medication logs. So just to kind of go a little bit deeper into this, already, Dr. Farley had implemented a universal PrEP protocol within BB2 so that all patients who are HIV negative at entry into study are assessed for PrEP awareness. And then that regardless of if the patient is aware of PrEP or not, that the nurse or medical officer would educate and offer PrEP. So if the patient wasn't aware, they would offer PrEP. If they were aware, they would just offer PrEP, but potentially answer any questions. And then, of course, ultimately, it's the participant's decision whether or not to utilize that. And so just a little bit about our sample that we looked at here. There were, at the time, this was through, I believe, the end of June 2024. So that at that point, there were 251 overall enrolled, and we limited that to the 110 participants who were HIV negative at enrollment. So you can see a little bit of the demographics of those who are HIV negative, not surprisingly, based on HIV epidemiology in South Africa, predominantly male. And then you can sort of see some other demographics and geographic breakdown there. But what I think we wanted to focus on is just report of some of these sexual vulnerabilities to HIV. And so, under a third of people are reporting condomless sex in the last 3 months at visit intake. So not necessarily a significant amount, but not no one. And as we see the breakdown of those who did endorse condomless sex, it is predominantly males who are reporting that. Among those who received syndromic treatment, there was just about 8%, so eight people only who were treated, and predominantly female there. But some data to suggest, increased biologic susceptibility to HIV with the concurrent STI. When we look at the HIV PrEP continuum, is I think where we realize there's a lot of room for improving the healthcare system and delivery models. Less than 40% of the population or sample was even aware of PrEP in the first place, despite something that is universally recommended for people at risk of HIV in South Africa. And interestingly, PrEP awareness was much higher among male participants, despite the burden of HIV infection predominantly affecting adolescent girls and young women in South Africa. And there's been a lot of attention to that important priority population, yet we see very little awareness in this sample, at least. And we see a big drop-off from even that awareness to even offering PrEP, despite the fact that the intention is it's universally offered. So, just about a quarter of patients are offered PrEP. And then from there, we see very, very significant drop-off to actual uptake of this intervention. So kind of if we wanted to just look at that by some of the HIV vulnerabilities that folks were reporting and see how that paired out by PrEP awareness and the PrEP continuum, you can see that for folks who endorsed condomless sex, less than half of them were PrEP aware, 40% were offered PrEP, and just 12% of people agreed to PrEP among those who reported as a potential behavioral vulnerability to HIV. And for those who were treated syndromically for an STI, only one person of those 9 or 11% was aware of PrEP, and only one of them was offered PrEP, and none of them agreed to PrEP. So again, if we're thinking about increased biologic vulnerability to HIV, that is a population that, although it's a small number in this sample, would be really important to think about prioritizing for PrEP uptake. And in following during this time, we did see that there was one incident HIV case that occurred during the study period among someone who was not taking PrEP, so who subsequently tested positive at a follow-up visit after their initial negative HIV test at enrollment. So, just conclusions, I think, we know that their vulnerabilities are present for both self-reported and symptom-based measures. The self-reported are probably underestimated for folks not feeling comfortable maybe disclosing that at the first visit especially. And there's not a lot of people benefiting PrEP despite, documented vulnerability and engagement in the healthcare system. And so this frequency of visits really does provide an opportunity to engage people in this important care. And there's a lot of people who need to be involved in finding ways that are accessible, feasible, and effective and sustainable, which is sort of a funny consideration right now, to integrate HIV prevention into TB treatment services. And we have a lot to draw on from the experience of integrating HIV treatment, but not prevention, but HIV treatment into TB services. And I know we're kind of at time, but I do want to just end both with a hopeful set of next steps, is to continue this work to improve PrEP uptake, and also add by piloting integration of molecular STI screening within this cohort. So for testing patients at entry into care for STIs, regardless of symptoms, and then subsequently if symptoms do occur, when STI symptoms occur, then using it as a diagnostic tool, which is not something that is currently being done, and see how that affects PrEP uptake. And so, Dr. Silvers, with the support of the Center for Global Nursing, is helping this, and hopefully some forthcoming support from the ASTDS group. So I'll leave that.
So we're happy to take any questions that you guys may have.
I have one, Jason, and thanks very much for the presentation. So tell me about the next generation of Bring Me Pal to Me that incorporates diabetes management and other aspects that fall under the primary healthcare or universal healthcare. Is that something that you're already picking away at?
Great question. So I'm looking for PhD students to analyze a slew of secondary data, because we are we are absolutely capturing. So for the students who don't know this, when someone's diagnosed with tuberculosis, because of integrated care models, they often, the TB focal nurse will take over their care of their HIV, their diabetes, their hypertension, and every other thing. It's not the same necessarily for the medical officer, but the TB focal nurse actually becomes their primary care provider, which is a difference in the strategy and system. So all of our nurses that we have are managing their diabetes and hypertension and referring liberally as they need it, because smear and culture convert so quickly on B-PAL-L. So, they'll reach out to a colleague when they're having difficulties. But we are seeing, I think we're up to our third CVA now in the data set in both arms. This isn't arm specific. We've had multiple cases of extremely high blood pressure that would require patients to be admitted. So they're at the cusp of seeing all the primary care issues and management. But because one of the all-cause mortality issues in our TB patients is that because care is referred away from primary care, often into the TB program, and the TB clinicians are not primary care specialists, many of our patients, we're actually doing a line list for every cause of death. So far, of our 9 deaths in the trial so far, only one is TB-related adverse event. So all the others are they've had a stroke. We have meningitis unrelated to TB. It was cryptococcal meningitis in a patient with HIV, and a variety of other things, including trauma and car accidents and gunshot wounds. But so what we're seeing is a really the workforce that we are seeing that is necessary for TB of the future in primary care includes chronic disease management in the strongest sense of the word. Yes.
Hi, Jason. Hi, Adam. Nice to see you in 3 dimensions.
I know, as opposed to online.
That was really wonderful. I kind of to pick up on that concept of integrated service delivery and chronic care models. I wonder if you could reflect a little bit about what it would take to kind of generate generalizable knowledge for other programs in other contexts to deliver care in a similar way. And you did a really lovely job throughout your talk flagging places in which you were partnering directly with policymakers and addressing their needs. But the comment you made about, the worry of the district referral hospitals in terms of are you the turf, right?
Yeah.
I think that's a really interesting challenge, and I just wonder if you could speak a little bit to the generalizable aspects of this infrastructure and what kinds of evidence helps convince people in public health that primary care is an acceptable solution.
It's a great question. So the first thing, the wonderful African proverb of, if you want to go fast, go alone. If you want to go far, go together, is a rallying cry for the work that I've done in the country. So our co-PIs, and I didn't take time to, as I went through the slide, the co-PIs, Norbert Njeka at the National Department of Health is a co-PI. It's his first R01, so I was really happy to get that, with that from him. And Prof. Denise Evans, also South African health economist, her first R01. So really, the goal being to try to galvanize the right key decision makers. And obviously, if you have the person leading TB for the entire Ministry of Health for the entire country, policy change isn't overly hard in that circumstance. But what I've actually had to do with my colleagues, so in 2013, when we showed our data related to the observational results of nurse-led treatment, the 2013 guidelines were in development. They were published later that year. So through that observational evidence, Prof. Njeka put it into the actual DRTB guidelines that observational evidence shows that nurses can do this in the place of physicians if there's no other physician to be. And I'm like, whoa, slow your roll. Actually, the opposite occurred in terms of making policy level change because they were so integrated into the approach. Moving toward generalizability. So one of the things that we've done, and we had to argue from a clinical trial perspective to keep the study as generalizable as possible, we got major pushback on our remuneration for patients by the IRB. The IRB wanted us to give clinical trial data level remuneration. So 400, 500 Rand. And I was like, absolutely not. That is, in our patients living in a township, who are many of which may be unhoused or marginally housed, 500 is totally coercive. I will not do that. And so it took 2 months in ethics review of getting them to agree to 100 Rand for transportation, 50 Rand each way. But we also placed, and I wish I could have shown you the cluster, the way we enumerated the clinics and got the clusters formed. The goal was to get a clinic within no more than 5 kilometers of a person's home. So 50 Rand in a taxi fare was actually acceptable. So we've seen, so first of all, we're trying to get it as pragmatic as possible. True primary care conditions. So if the x-ray doesn't work in the facility, that we have up to a month in the protocol to get the baseline x-ray, those kinds of things. To ensure that when we publish the results, and we can talk about the infrastructure in the physician arm and the infrastructure in the nurse arm, we're doing so without all the bells and whistles of clinical trial research. So that's what we're doing. All of our research assistants are trained at the level of a community health worker, because that's all we can really afford for a 275 clinic, 76 cluster randomized trial. And then we've had to actually build in a variety of PhD related sub-studies, because the $500,000 R01 cap isn't really large enough to do all the things we want to do with the study. Particularly, we've had to so far forego all our biorepository related specimens because we just can't afford them. So we're trying to give up a lot to make it as pragmatic as possible and generalizable as possible. But still, we get the pushback of how are patients selected for the trial, and how do we know we're not differentially taking patients to the nurse arm versus the doctor arm? And so we've thought about that a lot. So when a patient comes in, they are asked 3 questions. They're asked, where is your local primary care clinic? Where is your local ARV clinic if they're living with HIV? And with drug-resistant TB, where would you like to get your care? And between the answers to those 3 questions, they're offered care at the clinic that is the best proximity. They said, okay, well, your ARV clinic is associated with a DRTB program. We can get you care there. Would you like that? Or your clinic closest to home is associated with a DRTB program. We can get you care there. Which would you prefer? They choose, and whatever they've chosen, the clinic's already been randomized. So whatever they've chosen, and so what we're seeing right now is through that process of choice, we're actually going to have a whole set of secondary evaluations of, do patients choose to integrate their DRTB where they get their HIV treatment or not, those kind of things, to try to ensure generalizability and what does this mean as we try to scale it up. Sorry for such a long-winded answer.
That's great, thank you.
Thank you guys so much for coming, and thank you to those who joined us on Zoom. It's incredible to me to see the impact of nurse-led models of care across the globe. As we know, we are 29 million strong and have a lot of opportunity to truly impact patient outcomes, particularly in things like this infectious disease. So thank you to Dr. Farley and soon to be Dr. Leonard for joining us today. Thank you guys so much.